get started with my very first, with the presentation for this afternoon. And so this is my relevant disclosure as it relates to my work outside of ASHP and in my practice, but nothing that relates to this particular presentation. The learning objectives, I'm sure you've seen already, or you've seen a bunch of learning objectives over the course of the morning, but our learning objectives really focus around a complex patient primarily presenting with cardiovascular disease and caring for a patient with acute cardiovascular disease along with their other comorbidities such as decompensated heart failure, electrolyte abnormalities, acute coronary syndromes, and GERD. Develop a plan to address continuity of care, which we all know has become incredibly important in the hospitalized patient, how to manage that transition to care piece. We'll highlight that a little bit. Develop a plan for smoking cessation, which is, I'm sure you all know, is very important. Patients who have cardiovascular disease. How to manage drug-drug and drug-disease interactions. We do this all the time in our practices, regardless of where you are. Think about quality of life, benchmarking standards, and then recommendations for appropriate organizations or groups to help assist our particular patient. The premise is you're in a tertiary care academic medical center, and aside from that, you're going to be pretty much what you already are, which is a caring pharmacist who really cares about the patients that you see, providing strong evidence-based pharmacotherapy that the team relies upon you to do. And so with that, we have a 63-year-old patient, B.A., who's a Caucasian male, who wakes up with crushing substernal chest pain that radiates to his jaw, which he rates as being awakened from sleep as 9 out of 10 pain. He calls 911 and they come, the ambulance comes, the EMT comes and comes to his house very, very quickly and takes him to a local hospital. Now at that local hospital, he has an ECG done which shows ST segment depressions, and based off of that, this particular local hospital does not have the capabilities to manage him with the early invasive strategy, and so he's transferred to a hospital that actually has catheterization capabilities. But before they transfer him, they give him some standard therapies like nitroglycerin sublingually for 2 doses. They give him aspirin, 324 milligrams, and they give him a loading dose of clopidogrel. Just some past medical history before we see his exam when he comes to us in our hospital. So his past medical history is notable for hypertension, osteoarthritis, dyslipidemia, diabetes, coronary disease with a previous percutaneous coronary intervention or PCI, which was managed only with balloon angioplasty because that was the only thing that was available at the time he had his PCI. He currently smokes 1 pack per day, and his evidence-based medicines are he's on an aspirin, 81 milligrams per day. He's on lisinopril 20 milligrams per day and amlodipine 5 milligrams per day for his hypertension. He's on atorvastatin 20 for his dyslipidemia. He's on metformin for his diabetes. And he takes ibuprofen 3 times a day for his osteoarthritis. When he comes to us at our hospital, he's noted to have, again, greater than 1 millimeter ST depressions in lead 1 through 4. That's more of a nice-to-know point. As pharmacists, we don't read ECGs. We're not expected to do that. But just as an FYI, things that I've absorbed through osmosis, just being on a card service for so many years, this represents, essentially, this is very suspicious of LAD territory, the anterior part of the myocardium. So that is somewhat concerning just based off of the ECG alone. He does have some mild inspiratory and expiratory crackles about a quarter of the way up both lung fields bilaterally with a little bit of trace edema in his lower extremities. But really most concerningly, we have positive cardiac biomarkers. So he has a positive troponin, his CK and CKMB are up at this point in time early in his presentation, which somewhat makes sense based on the abnormalities we saw within the territory, with suspected LAD territory. So it's not surprising that early on he's already made some positive biomarkers. We have a Chem7 with a calcium and a magnesium noted here as well. And so with that, we're going to get started with our first question, which is, which of the following represents the best initial anticoagulant pharmacotherapy? Is it unfractionated heparin? Is it enoxaparin? Is it fondaparinux or bivalirudin? Oh, that's so much better, thank you. Okay, so the majority, thank you, has selected unfractionated heparin, and I would agree with that as the initial best choice. And I'll walk through why. So 30% thought enoxaparin, not a bad choice. I'll try to explain to you why I thought heparin was the best choice. Nobody picked fondaparinux. That's probably a good thing. for our patient, and only 8% picked bivalve. Okay, so what I'll do for this first part of the presentation is I'll kind of walk you through what the guidelines have to say, and then walk you through some of the evidence behind the guideline developed statements to try to give you a deeper dive into what the guidelines have to say. And so when we think about non-ST segment elevation acute coronary syndrome, which I'll either call non-STEMI or NSTEMI or NSTE-ACS, I'll kind of use all those terms interchangeably just because the literature does, or I'll probably use NSTEMI for the most part because it's the easiest for me to pronounce. But we think of NSTEMI as a platelet-based disorder, but anticoagulant therapy is still important in the early aspect of the management of these patients, and so that's what the guidelines mention here, and you'll see that they give a variety of recommendations. So unfractionated heparin has a class 1B recommendation, whether or not you're giving it in combination with the glycoprotein 2B3A receptor antagonist. It has a similar recommendation for Bivalirudin with the doses listed here for you. Now this is the pre-PCI dose, which is much lower than the intra-lab or in-PCI dose. That's a much higher dose. So early on, if you start Bival upstream, so to speak, you can start it, but it's a much lower dose than you would see than what's actually used in the lab. Enoxaparin for overall NSTEMI has a slightly higher recommendation of class 1A. Now, some of the reasons for that has to do with, if you look at the totality of the enoxaparin data, you have to keep in mind that when we think about the overall management of NSTEMI, not everybody ends up needing to go to the cath lab. There's some patients that present too late. There's some patients who present in a manner by which taking it to the lab would provide no benefit, and there are other patients who really aren't candidates for PCI. And so for patients who present that way, we call those patients medically managed patients. So if you look at the medical therapy patients, especially in the late 90s, there were head-to-head studies comparing enoxaparin to unfractionated heparin, which suggested a benefit of unfractionated heparin of enoxaparin over unfractionated heparin. It goes back to the late 90s. The Essence and TIMI 11B trials were 1997, 1998, respectively. If we think about the modern era, trials where, after the late 90s, PCI kind of came into play in the early part of the 2000s. So if you look at the studies in the PCI era, comparing enoxaparin to unfractionated heparin, what you see in the PCI era is that advantage that existed in the late 90s with low molecular weight heparin disappeared in the era of PCI. And more importantly, there's an increase in major bleeding in the enoxaparin-treated patients compared to the unfractionated heparin-treated patients. These were studies like Extract, TIMI 25. These were studies like the Synergy trial or 2. And there's a meta-analysis that was published in 2005, which for NSTEMI showed that there really wasn't an ischemic benefit to using enoxaparin. And there's only increase in major bleeding. So the guideline recommendation has to cover all of it. So if you're just managing patients medically, it's reasonable to use a low molecular weight heparin because there was a benefit to be gained over continuing a heparin infusion. But in the invasive strategy in the PCI era, that advantage disappears at a cost of an increase in major bleeding. Fondaparinux has a class 1B recommendation. Similarly, the strength in NSTEMI for fondaparinux has to do with less bleeding and in the medically managed patient population. In another slide, I'll talk to you about what fondaparinux looks like in patients undergoing PCI. So, thinking about bivalve versus heparin, now most of you didn't pick Bivalirudin, but those are the two sort of continuous anticoagulants that can be considered in the cath lab. There were two studies that have compared unfractionated heparin to Bivalirudin. This is the NSTEMI trial called the ACUITY trial. The STEMI trial was called the Horizons AMI trial. So we're just talking about ACUITY here because this is what our patient has. This patient has NSTEMI. And so this was somewhat of a complex trial where there were three arms. There was the heparin plus 2B3A arm. There was the Bivalirudin plus 2B3A arm, and then there was a Bivalirudin alone arm. And we'll sort of talk about the data with all three of those agents overall, those three of those arms respectively. Patients then had to have angiography within 3 days, and then they stratified based on whether they had medical therapy, so they didn't get stents placed or didn't go to PCI. The patients who had PCI, then the patients who, based on the PCI data, they needed to have coronary bypass. There's just too many lesions to stent, or those patients would have done better based on where those actual blockages were. They would have done better with a bypass graft as opposed to stenting. And so, thinking about the overall results with what was observed, so you'll see that this is now the enoxaparin, this is the unfractionated heparin or enoxaparin or the heparin arm with the 2B3A inhibitor versus Bivalirudin, with a 2B3A inhibitor, and you'll see that there was really no difference overall between the two arms with regards to the overall net clinical outcomes. The net clinical outcome is the combination of these two bars right here. So it's the combination of the ischemic endpoint plus major bleeding, but regardless, you can see here there is no difference. They did meet their statistical criteria for non-inferiority, but they were not able to show that bivalirudin was superior, and that was their main objective, to show that bivalirudin was better than the heparin 2B3A arm, and that did not happen. In the bivalirudin alone arm, surprisingly, they were able to show a net clinical benefit, but that was driven by a reduction in major bleeding. The ischemic endpoint, as you can see here, actually favors the heparin 2B3A arm compared to compared to the bivalirudin arm, but the bleeding outweighed the overall ischemic endpoint, so their version of the net clinical benefit outcome was tipping in favor of bivalirudin. But there's a little more to the story, and so this slide here actually is a really good practice of what Dr. Tyler would have talked to you about this morning in applying statistics and thinking about non-inferiority trials and how you define a non-inferiority margin. And this is one of the areas where this study's received a lot of statistical criticisms. And the reason I say that is I've highlighted for you the ischemic endpoint, which I showed you on the first slide. If you look at the bar graph, you say, well, it's kind of close, right? It's 7.8 versus 7.3. I mean, yeah, it's lower in the heparin 2B3A arm, but it doesn't look terrible. Now, in order to meet non-inferiority, they define the upper bound 95% confidence interval at 1.25. And so you know that for non-inferiority, that basically means that they're similar to, right? And the 95% confidence interval is a capture of what we think the true population mean would be, right? And so the way they define non-inferiority is they basically set that at 1.25, which basically means that the bivalirudin for the ischemic endpoint can be 24% worse. The true mean can be 24% worse than heparin and still be considered non-inferior. That doesn't make a lot of sense, right? I mean, that sounds like it's a pretty broad confidence interval, and that's what where they received the criticism the most for was they took a very liberal definition of non-inferiority. Looking at the way that we traditionally, or the way in which we mathematically define non-inferiority and the principles by which you should use strict non-inferiority criteria, many have said that the non-inferiority margin for the ischemic endpoint in this trial should have been 1.13, half the effect size anticipated. They used the full effect size. And so, as you can see, the upper bound hit 1.24. So yeah, they got non-inferiority, but some have argued it's because of the looseness by which they define non-inferiority, because of the fact that they didn't use a strict criteria. So that's sort of the reasons why, along with cost, as you all know, bivalirudin is far more expensive than unfractionated heparin. But this is some of the reasons why the ACUITY trial has been criticized, and why overall in NSTEMI, unfractionated heparin is the preferred agent. In the STEMI population, there's actually a little bit more stronger randomized controlled trial evidence that supports bivalirudin over unfractionated heparin, and pathophysiologically, to me, that makes sense. When you think about STEMI, you think about a clot that is more fibrin, thrombin, red cell driven, whereas in NSTEMI, we're thinking about more of a platelet-based thrombosis. So in STEMI, there's better data, but in the past 2 to 5 years, there's been a number of trials that have come out head-to-head in a variety of sort of not necessarily randomized controlled trials, but there have been a lot of studies comparing these two agents head-to-head, and we have very conflicting results overall. And so the two trials last year and the year before that received intense scrutiny and intense media were the HEAT PPCI trial and the BRIGHT trial. And you can see there are very, very conflicting results. So in the HEAT trial, you'll see that with unfractionated heparin compared to bivalirudin, there was really no benefit at all to bivalirudin in any endpoint. The ischemic endpoints were far better with unfractionated heparin. There was no benefit gained in major bleeding, and there was a significant increase in stent thrombosis in the bivalirudin-treated patients. And in the BRIGHT trial, we had the exact opposite results, where the ischemic endpoint looked better, the bleeding looked better, and there was actually no difference in stent thrombosis, even though it was numerically higher in the unfractionated heparin-treated patients. And so, like most things that we do in cardiology, we take data dives, and then a lot of smart people get to publish these meta-analyses. And so this was a meta-analysis that was published taking into account a variety of clinical trials. This is the Horizons. This is the largest randomized trial that has studied bivalirudin. That's a STEMI trial. So I didn't talk about that because it doesn't fit our patient. But that's the STEMI trial. And then I talked about HEAT and BRIGHT. So overall, you can see with major bleeding, there does appear to be an advantage to bivalirudin. Bivalirudin causes less major bleeding than unfractionated heparin does. And that's kind of been a uniform theme that's been developed throughout the overall trials. However, that does come with a price to pay, and that is an increase in stent thrombosis. And so it kind of makes us in the cath lab pause a little bit to think about what is the ultimate best agent for our patients and how do we manage the rest of the pharmacotherapy if we're going to use Bivalirudin versus unfractionated heparin. And so it gives us somewhat of a double-edged sword. Just to round out the dosing, another thing I haven't talked about yet with enoxaparin, but enoxaparin in the cath lab is a little more challenging to use because you really have to know when the patient received their previous dose. And if it was within 8 to 12 hours, you can actually forego it, but if it was more than 8 to 12 hours, you have to redose. And it's a dose of 0.3 milligrams per kilogram given intravenously. And for patients that haven't received anything, it's 0.5 to 0.75 milligram per kilogram intravenously. Bivalirudin is pretty straightforward. You either you continue it in the lab and just increase the dose, or for patients who haven't been on it, you gain access, and then you just use the high dose, right? So you saw the low dose in the previous slide. This is the intra-PCI base dose. It's a higher dose than what you will see for any other continuous infusions of Bivalirudin. With fondaparinux, fondaparinux cannot be used as the only anticoagulant for PCI. And nobody picked fondaparinux, so that's totally fine. You guys were all on the right track. But just so you know why you shouldn't have picked C, it's because for patients who receive fondaparinux at any point in time pre-PCI, they have to receive a heparin-based anticoagulant during PCI. So while fondaparinux looks attractive for medical therapy in the invasive strategy patients, it tends to cause catheter-related thrombosis. And that's one of the two most feared complications that occurs during PCI. Okay, and so in order to mitigate the catheter thrombosis that was observed in the trials with fondaparinux, everybody had to get unfractionated heparin. So if you're picking C for PCI patients, you're better off picking A, which was a fractionated heparin, because those patients would have to get heparin in the lab regardless of the fact they got fondaparinux. And then this is just to round up the dosing for unfractionated heparin based on whether or not you're using a GPI, which is another way to say a 2B3A receptor antagonist, so drugs like eptifibatide or tirafiban or abciximab. Here's the data for the 2B3A receptor antagonists. So in patients who have not received an oral P2Y12 inhibitor or an oral antiplatelet in addition to aspirin, it's a class 1A recommendation. For patients who have received heparin and clopidogrel or any other P2Y12 receptor antagonist, it's a softer recommendation. You don't have to do it. It really depends upon how the case is going, so to speak. So this is really where we would default to the cardiologist and the proceduralists to say, well, yeah, things are running smoothly. We've gained access. We're not worried about thrombosis, not worried about platelet aggregation. So this is kind of what we call the, if you ever see this term in the literature, this is the quote-unquote bailout. So if there are complications that are occurring during PCI, this is where the 2B3 receptor antagonists come into play to essentially obliterate platelets even more, because we think that they're a little too angry and hyperactive. So up front, this is kind of called upstream. You can consider it in patients who haven't received an oral loading dose of some other agent on top of aspirin. That's typically our 3 different P2Y12 receptor antagonists. If they have not, you can use it. If they have, you can think about this box right here. Okay, so for our patient, even though he received a loading dose of clopidogrel at the outside hospital, he received unfractionated heparin, as you suggested, and he received eptifibatide. After PCI, the heparin is discontinued, and we're going to continue the 2B3A receptor antagonist for 18 hours. That's what the data and what the labeling says for these agents. If you start them in the lab, you have to continue them for 18 hours for the most part, and the team's going to talk about how to manage the rest of his therapy thereafter. However, the next morning on rounds, we noticed something kind of funny, and his platelet count is now dropped to 10, down from a baseline of 175. His hematocrit and hemoglobin are stable from his initial presentation, and there's no evidence of bleeding on thrombosis that have been noted on physical exam, which is good news, but we have a low platelet count that is very concerning. And so, which of the following medications do you think was most likely contributing to our patient's thrombocytopenia? Do you think it's unfractionated heparin? Do you think it's the eptifibatide? Do you think it's the clopidogrel he got as a load? Do you think it's the aspirin that he's been taking? Okay. 46 appears to be our magic number. All right. And survey says, most of you think it's unfractionated heparin. Interesting. Okay. I'll tell you why I think it's eptifibatide. Okay, so when we think about thrombocytopenia, in general, we can think of a variety of different mechanisms by which thrombocytopenia can take place. So it can either be an underproduction from the bone marrow, And now when that typically happens, it's usually not just platelets that are affected. It's usually other cell lines that are down as well. So it's a bone marrow-based problem, and the bone marrow doesn't discriminate and only reduce platelet production. It tends to reduce all cell lines altogether. We can have an increase in destruction or an increase in consumption, and that can be antibody-mediated clearance, or that can be consumption as in the platelets are now being used to form these clots, to form thrombi, and that's why the count is down. Or this can be redistributed, usually into the spleen. So those are three basic concepts by which anybody can have any type of thrombocytopenia. So not thinking about just drugs, but any type of thrombocytopenia. You can almost lump this into this category. There is a fourth. I didn't put it on the slide. I probably should have. It's pseudo-thrombocytopenia. And that can be because the platelets react to the EDTA in the test tubes for blood draws. And that can actually cause a thrombocytopenia from clumping. But that's not a real thrombocytopenia. That's just basically what happened in the test tube. That's not what's happening in the patient. So when we think about drugs, drugs fall under the table of either destruction or consumption, okay? And we can break this down a little bit further, and the rest of this is just for the sake of completeness. We're rarely consulted on a variety of these other disorders. We're often consulted when somebody thinks it's a drug, right? So this is where I'm going to dive down a little bit deeper in thinking about drug-induced thrombocytopenia. Okay, so here's a complex table, and I'll apologize up front, but there are a variety of medications that have been implicated. The data for all the medications is really, unfortunately, not all that strong. Even with the most commonly reported drugs that have been associated with thrombocytopenia, you're looking at incidences of like 10 to 15 per 100,000 or per million. So these are rare events overall, which is probably a good thing considering how thrombocytopenia can be devastating. And we have a variety of mechanisms by which drugs can cause thrombocytopenia. Just to break this down a little bit, so hapten, basically, a hapten is anything that can be called like an antigen. Any molecule that can trigger antigen development can be called a hapten. And so in our case, when we think about drug-induced thrombocytopenia, the drug is the molecule, so that's why the drug is also referred to as a hapten. Okay, but so they're taking the generic term hapten and applying it to a medication. And then an epitope or a neoepitope is basically that is a portion or a protein or a complex or anything that is recognized as foreign. And so the drug plus a protein, the drug plus a receptor, the drug plus any other protein is being recognized as foreign. That foreign material that has been created, that's called an epitope, and that's what the antibodies are reacting to. And so you can see that for the most part, when we think about drug-induced thrombocytopenia, what we're worried about is hemorrhage. The majority of these mechanisms all could result in hemorrhage, with one exception, and that's heparin and low molecular weight heparin, which we all know is HIT, and HIT, we're not worried about bleeding, we're worried about thrombosis, right? So I think that's what you were all worried about. With regards to timing, I'll talk a little bit about timing, but with regards to the profound reduction in platelets, that's usually a strong antibody-driven process. And if we look across all of these drugs that are more likely to give you that type of rapid and profound thrombocytopenia, it's the 2B3A receptor antagonists that give you that profound level of thrombocytopenia. There are other agents could have caused thrombocytopenia as well. You all liked heparin the most, but clopidogrel also has a thrombocytopenia associated with it, but they're all sort of different with regards to their etiologies. So with clopidogrel, in TTP, this is another type of thrombocytopenia, but in TTP, you have multiple cell lines that are down. Okay, so it's not just the platelets that are down, but you usually are going to see things like hemolytic anemias or renal injury. You'll see an increase in LDH and an increase in indirect bilirubin, usually from hemolysis. So that's where you can rule out, in our patient, we can rule out TTP. Didn't complain of abdominal pain, I didn't tell you anything about nausea or weakness or anything else like that, and his hematocrit and hemoglobin were stable. Okay, so that's ruling out TTP. With clopidogrel, if you think about clopidogrel and TTP, the time course is usually within the first 2 to 3 weeks. Now there is a range of anywhere from 3 to 21 days, but it typically, if you look at the majority of the case reports, looking at, it's still early, but 2 to 3 weeks. So it wouldn't be within the first 12 to 24 hours after drug exposure. And while the platelet count can be severely low, which would mimic what we have with our patient, in patients with clopidogrel-induced TTP, the hematocrit is usually less than 27, and that did not happen to our patient, right? The patient had a stable hematocrit in the 30s. So with HIT, The 4T's risk score is a good way to think about whether or not you're worried about heparin being a contributor to a patient's thrombocytopenia. And the 4T's stand for thrombocytopenia, timing, is thrombosis is present, or other causes of thrombocytopenia. So I'll walk you through how I calculate the 4T's for our patient. So when you think about thrombocytopenia in general, HIT, while causes thrombocytopenia, rarely gives you thrombocytopenia with platelet counts that fall less than 50. And certainly not down into the 10 range. The nadir is usually in the 50,000 range. And so you can see that while he had the fall of 50% from baseline, the nadir was not above 20,000. It was less than that. It was at 10,000, right? So that doesn't quite fit there. With regards to timing, while there is acute cases of HIT in patients who've been predisposed to heparin in the past, the majority of cases occur after 5 days of heparin exposure. The classic thing is 5 to 10 days after the heparin has been started is where you start to see the thrombocytopenia, okay? And so in our patient's case, it fell to less than 4 days, and I didn't tell you anything about past heparin exposure, but in my head, as I was thinking about the patient I was talking about, he hadn't been in the hospital within the past 3 months, and so that wouldn't fit with having someone have an exposure within the past 100 days. If you wanted to split hairs with me and score 1 point here, I wouldn't disagree with you. If you wanted to do that, I think that's fine. Now, with thrombosis, I think, based on what I told you, there was no thrombosis present, right? So there's 0 points there. And are there other causes of thrombocytopenia? I would argue yes. He's been exposed to 3 medicines that have been associated with thrombocytopenia. So besides the heparin, the 2B3A receptor antagonist, and clopidogrel. And so even if you want to split hairs with me with regards to the timing, you'd still have a score of 1, which would be low. And I scored him at 0 because I thought there really was no evidence of HIT here at all. So this is kind of another pictorial way in which you can think about the different mechanisms by which drugs can cause thrombocytopenia. So this is sort of, in this paper, this was the classic drug-induced thrombocytopenia model, where the drug then is the hapten, and then this is recognized, this complex here is recognized as foreign, which causes an antibody response to the platelet, which causes platelet destruction. For 2B3A receptor antagonists, the reason why it's so profound is it's the drug that then changes the overall conformation of the 2B3A receptor, and then it's this complex right here which is recognized as the epitope, and so you have the antibody targeted to the receptor. And when you think about activated platelets, there are approximately 100,000 2B3A receptors that are uploaded onto the platelet during activation. And you think about a small molecule like eptifibatide, a lot of those are going to be occupied by the drug. So you have a lot of drug receptors occupied together that have caused this conformational change. And once the antibody responds and recognizes one of these as foreign, it's going to recognize all of them as foreign. And that's why you have that rapid destruction of platelets. And that's why you saw the profound drop in timing, a profound drop in thrombocytopenia. Heparin, as you all know, is a platelet factor 4 driven process. And it's sort of a vicious cycle. Right, so as you have antibodies that form to the heparin platelet factor 4 complex, if those platelet factor 4 antibody complexes bind to platelets, they actually cause platelet activation, which releases more platelet factor 4, which then binds to heparin. You have the antibodies that are already circulating, so it creates the vicious storm. And that's why you see the thrombocytopenia develop, and that's why you get thrombosis. It's because you're triggering activated platelets that are then triggering more thrombin. And that's why we're worried about thrombosis. The platelets get used for an HIT for thrombosis, not from a destruction. It's from activation and consumption and developing a thrombus. This is just a pictorial graph kind of trying to look at the timing and where the nadirs fall between a variety of medications. So this is HIT, where again the nadir is usually in the 50,000 range or so, or higher, because it's a 50% drop from the patient's baseline, okay? Whereas when we think about other drug-induced immune thrombocytopenias, you're really looking at a much, much lower nadir. And as I mentioned, for these thrombocytopenias, you worry about bleeding, whereas heparin is one of the rare drugs where when you have thrombocytopenia, you're worried about thrombosis as opposed to bleeding. Okay, so having moved on from that, we're now going to think about what we can do for this patient for dual antiplatelet therapy. So which of the following has been associated with reduction in all-cause mortality in combination with aspirin for ACS? Is it ticagrelor? Is it prasugrel? Is it clopidogrel? Or is it ticlopidine? So which one has a reduction in all-cause mortality? my other disclaimer here is help me help you. So the faster you get your answers in, the faster we go through the whole thing. So we're not going to get to our magic number. Oh, there it is, 46. All right. All right, so mixed results across the board. The majority think clopidogrel, 17% prasugrel. So remember, the question I asked you was about, in clinical trial data, which one had a reduction in all-cause mortality? Okay, so that was the specific question. Not which one you thought would be okay for the patient to take, where you could argue that any one of the three would be a reasonable option. So it asked you a little different question. So let me walk you through that. So just a snapshot again of what the guidelines have to say about our oral antiplatelet agents is that for patients who have not been adequately pre-treated, we use a 2E3A receptor antagonist. For our oral antiplatelets, in 2014, the ACC-AHA, the guidelines finally united with the Europeans in that they recommended, not strongly, but they did actually recommend either ticagrelor or prasugrel over clopidogrel. It took them only about 5 or 6 years, and actually the Europeans took a little bit of time as well, but technically if you think about just guideline recommendations, while these are not strong recommendations, they actually did say that you could consider the more potent, faster-acting, newer, stronger antiplatelets over clopidogrel. With ticagrelor, that can be anybody with NSTEMI based on the way it was studied, whereas for prasugrel, you'll notice that it is slightly different and that the recommendation is really only for patients who want to go PCI. And it has to do basically with the way in which those two drugs were studied for this particular indication. For prasugrel, everybody had to get PCI, whereas in the study I'll present with ticagrelor, they allowed for both medical therapy and for the early invasive strategy with PCI. And so this is the Plato trial. This is the landmark trial, so to speak, that led to ticagrelor's approval worldwide for the indication of ACS and NSTEMI, or STEMI, excuse me. So it was a head-to-head trial in 18,000 patients compared to clopidogrel. Everybody got 300 milligrams of clopidogrel in the clopidogrel arm first, and then they could get another dose to get to the more appropriate 600 milligram dose, followed by 75 a day. Whereas in the ticagrelor, it was dosed as we know it is now in the United States, post-PCI or post-ACS, 180 milligram load and 90 milligrams twice a day. The primary endpoints, the primary endpoint was cardiovascular death, MI, and stroke as a composite, and then major bleeding was the safety data. And so here's now all the results that were achieved in the Plato trial. So the composite primary endpoint of death, MI, and stroke was significantly lower in the ticagrelor-treated patients compared to the clopidogrel-treated patients. And then breaking down the secondary endpoints, what you'll see is that there was a reduction in MI, there was a reduction in CV death, there was no reduction at all in stroke. So this composite primary endpoint was really driven by the reductions in cardiovascular death and MI. Stroke was neutral between both groups. Now, surprisingly, they also noticed a reduction in all-cause mortality compared to the clopidogrel-treated patients. And this is the only trial, this is the only drug from an antiplatelet perspective that has actually shown that reduction in all-cause mortality. Even if you go back to the clopidogrel era in the early part of the 2000s, go to the CURE trial, the CRADO, all those trials that led to clopidogrel's decade plus of dominance, all that data, if you look at it, surprisingly, it didn't reduce mortality. It reduced MI compared to aspirin alone, which is what kind of was the foundation of dual antiplatelet therapy and the foundation of clopidogrel, but didn't actually reduce death, didn't reduce mortality in any way, shape, or form. Why this drug reduced mortality in this trial is not 100% known, but it did actually show a benefit. Now, there was a price to pay, so to speak, and that was major bleeding. The other thing that I use this slide for is anytime you look at ACS trials, whether it's an anticoagulant or an antiplatelet, and you look at major bleeding, look at how they define major bleeding, because it's rarely a uniform definition. On the venous side of things, a lot of times the bleeding definitions are pretty standard. They use one definition. On the ACS side of things especially, there is no uniform, well, there actually is, but people don't necessarily use it. And studies use their own definitions of major bleeding. And so, I mean, you've got TIMI major bleeding, you've got Gusto major bleeding. This group came up with their own Plato major bleeding. So you really have to look closely at how they actually, what counts as a major bleed. Because for TIMI major bleeding, for example, you almost have to exsanguinate before you actually get a major bleed. It's like a massive hemorrhage. And the TIMI minor bleeding, which it's called minor bleeding, but it's actually a pretty significant bleed that counts as minor bleeding. So look at how they define it, because it's not always uniform, and you'd be surprised at what actually counts. Okay, so moving forward, our case continues. We stopped the 2B3 receptor antagonist, obviously. That was driving the thrombocytopenia. His platelet count recovers very rapidly. So we took away the antigen. It's now at 124,000, so it's on its way to recovery, on its way to baseline, which is what we wanted to see. So which of the following represents the most optimal dose of aspirin for a patient BA? So is it enteric-coated aspirin, 81 milligrams indefinitely? Is it enteric-coated aspirin? We're going to use the high dose for 6 months and then drop down to 81 milligrams of enteric-coated aspirin thereafter? Or do we not care about the coating? Is it just plain aspirin, 81 milligrams indefinitely? Or is it plain but high dose, adult dose, so to speak, aspirin 325 indefinitely? What do you think about that? There we go. Oh, you guys tricked me. 48 is now the magic number. Okay, let's see what we got. Okay, I would agree with the majority here, definitely. 81 milligrams of plain aspirin would be the best choice. Okay, so not surprisingly, the guidelines give aspirin a class 1A recommendation. So we use aspirin in all of our patients. It actually happened earlier in the PCI guidelines in 2011, but it literally has taken us decades to think about aspirin the way the rest of the world does, and that more is not necessarily better. The Europeans have been doing this for decades upon decades, whereas in the U.S. we still tend to use 325, but a variety of guidelines, so the ACC/AHA, starting in 2011, have actually said that they recommend 81 milligrams of aspirin a day over other doses of aspirin. It's not the strongest of recommendations, but they at least have finally kind of at least placed that language in to match what the Europeans and other guidelines have advocated. Now, with regards to enteric coating, this is a small healthy volunteer study, but I think, as you know, for me as a pharmacist, I think it was somewhat interesting because they actually the main difference was the formulation. So it was enteric coated aspirin versus plain aspirin in 400 healthy volunteers. And now they didn't look at outcomes; they looked at platelet reactivity. But in theory, we think that the platelet reactivity would correlate to the outcome as it relates to antiplatelets to a certain extent, right? I mean, if you don't have if you have platelets that are reacting, then we think the antiplatelet therapy is not working as well as when they're non-reactive, right? So that's kind of the premise behind this study. And what was interesting was that in the patients who received just plain old aspirin, everybody responded exquisitely. So they all had a beautiful antiplatelet response. So the platelets were all quiet, there weren't angry platelets, the platelet reactivity was very, very low. In the patients that received enteric-coated aspirin, anywhere from a quarter to almost a half were deemed as non-responders. And it actually took multiple doses to convert these patients. So they ultimately did convert, but it took multiple doses from these patients to actually get to the same level as that one single dose of plain aspirin. Now, call me crazy, but what does the enteric coating actually do from clinical outcomes? Is there any data that says it actually reduces GI bleeding compared to the non-enteric coating? I'm not aware of any permanent, at least strong data that suggests that. And so in our institution, we've actually tried to really minimize our stocking of enteric-coated aspirin on our cardiac floors and just use the plain aspirin in the cath lab because everyone, if they haven't gotten aspirin yet, they have to chew it. We always use the baby aspirin, so they have to chew that, so we're okay there. But just keep in mind that the enteric coating, not necessarily any safety data, and surprisingly may actually be detrimental. And remember, while it did take multiple doses to correct, in patients that have just received stents, we don't want to take a risk with them having suboptimal aspirin exposure, right? That's where they're most vulnerable for having stent thrombosis, and so it's important for us to have adequate and appropriate therapy, and the enteric coating may actually be hurting us at that time instead of helping us. Okay, so now that we've placed him on low-dose aspirin indefinitely, we're going to place him on one of the P2Y12 receptor antagonists as well. And so what is the most appropriate duration of dual platelet therapy, or DAPT as we'll refer to it from now on? So is it 1 month of DAPT? Is it 6 months of DAPT? Is it 12 months of DAPT? Or is it 30? Okay. Survey says, wow. All right. It's a strong split. You guys are all going to hate me, though. All right, let me walk you through why I think 30 months is kind of odd. I was wondering if that'd be too easy just because it's like 30 months, like that's kind of random, right? So wow, 30 even lost out to 1 here. That's interesting. Okay, let me walk you through my rationale. My full disclaimer here is, the space between my ears is a dangerous place to be, but I will walk you through why I think 30 months is the best. So, with regards to what the guidelines say, the guidelines are pretty generic overall. They say that for patients with NSTEMI who have received a drug-eluting stent, it should be for at least 12 months. You can pick whatever agent you want at whatever dose. They're all Class 1B recommendations. So it says at least 12 months, all 1B. Okay, so to try to address the question of what actually is the risks and benefits of continuing beyond 1 year, that was the DAPT or DAPT study, which was published in 2014. And so the main objectives of the DAPT study were basically to see, after 1 year, what are the risks and benefits of continuing dual antiplatelet therapy. And so what they were looking at was either a reduction in stent thrombosis or a reduction in major adverse cardiovascular or cerebral events, which they called MACI. And the way they defined MACI was a composite of death, MI, and stroke. Now, they also wanted to look at what the impact would be with regards to moderate or severe bleeding for patients who continue dual antiplatelet therapy versus those that stop. So what's the risk-benefit? So this is the design of the DAPT study. So you see that everybody in DAPT got 12 months for free. And then at that point in time, they were randomized to continue dual antiplatelet therapy for an additional 18 months, which is where you get the 30, or placebo. And remember, this is a duration trial, so they didn't really care what stents people got. They didn't care what type of DAPT people used. It was really all about duration. And so, I think I have another slide that highlights it, but in case, it's not obvious. So the majority of patients got clopidogrel, the rest got prasugrel, but that wasn't the objective. It was just duration. Okay, so they're randomized to 30 months total versus just the 12, and everyone got placebo for the 18 months. And then, at 30 months, they did something interesting. They stopped the trial, but then they followed everybody for an additional 3 months to see what does this population look like now that they're all equal for the final 3 months of the study. Let's see if there's any data we can glean from there. And so, looking at that primary endpoint of MACI, so major adverse cardiovascular or cerebral events. And so, what you'll see is that early on, within that first 3 months, there was a pretty significant difference in the patients that continued dual antiplatelet therapy versus those that didn't. And if you look at these curves, it kind of, not that we should do this, but it kind of looks like it separates out all the way to that first year, and then it continues thereafter, right? So the reason I'm highlighting that is, remember, at 30 months, everyone stopped, and then they looked to see what happened for 3 months. And at the end of that 33-month period of time frame, in the 3 months here, where everybody stops and is only on aspirin, this curve starts to catch up a little bit, suggesting a loss of protection from dual antiplatelet therapy. These curves are starting to pinch together a little bit. They separated pretty quickly early on, stayed that way while the study was comparing dual antiplatelet therapy versus not, and then here, perhaps, you're starting to lose protection. With regards to stent thrombosis, pretty similar, right? So early, within the first 3 to 6 months, you can see that these curves are different. There's a protection in stent thrombosis in the patients who were on therapy versus those that were not. It persists, and then at 30 months, it's kind of hard to see, but these may be coming together. With regards to just myocardial infarction, again, early benefit that was observed in the first 3 months or so persists during the time that the study was stopped, and then once the study is stopped, everyone observed the curves are starting to come back together again. And importantly, not all MIs were caused by stent thrombosis. And in fact, more than half, 55% of the MIs that occurred in the DAPT trial were completely unrelated to stent thrombosis. So yeah, we're using the dual antiplatelet therapy to protect the stent, but these patients also have coronary disease, and we're using dual antiplatelet therapy to protect them from subsequent events also. And so this suggests that there are dual benefits to continuing dual antiplatelet therapy. Okay, so here's where I'm going to confuse you a little bit and hopefully kind of make things a little bit clearer in about 2 minutes. So with regards to the safety side of things, so you see that it makes sense. Like, so for the efficacy side of things, hopefully you can see that there was a benefit to continuing dual antiplatelet therapy, but there was a price to pay. So when you look at moderate to severe bleeding, that was increased by almost 1 absolute percent in the patients who received dual antiplatelet therapy versus didn't. It was driven by moderate bleeding, but nevertheless, when you think about our patients, they don't like to have bleeding in general, right? So overall, there's the price to pay, right? So now we're left with this, yet again, a double-edged sword. Yeah, there's a benefit in MI. Yeah, there's a benefit in stent thrombosis. There's a benefit overall, but there's the price to pay. So how do I pick, right? How do I know who can continue versus who can't? And we now have potentially a way to identify patients who would be better off continuing or better off discontinuing doing platelet therapy. So from the DAPT study, it's actually been published in JAMA as of a couple months ago, but if you want the actual risk score, it's easiest just if you go to the website, daptstudy.org. They actually have the calculator. So if you're familiar with like the CHAD score for estimating stroke risk in AF, it's kind of along those lines. It's not as easy as to remember as CHADS, but this is basically a scoring system that will help us identify what patients would benefit from continuing at 12 months and beyond versus those that would benefit from stopping dual antiplatelet therapy at that 12-month period of time. And so the objective was to see if they could identify clinical and procedural-based characteristics that they could then provide a score for. Now remember, it's derived from the DAPT trial. So when you read the study, look at the exclusion criteria, because that may not apply to every single patient that gets stented where you have to make this decision. So it's derived from the DAPT cohort, so your patients have to kind of look like the DAPT cohort. So just keep that in mind. This isn't going to be something that you can necessarily apply to every single patient at this point in time, but at least it gives us a place to start. So how do you calculate the DAPT score? Well, you've got patient characteristics and you've got procedural-related characteristics. So you can see that you need to think about age, comorbidities like diabetes and smoking. Does the patient have an MI in the past? What's their ejection fraction like? And then for the procedure, was it the MI that caused them to have the stent, or was it something else? And then where's the stent located? Is it a vein graft and is it a small stent? And so as you add up the points, you can see that you're going to end up with a score anywhere from -2 to 10. But it actually gets a little bit easier from this point forward, okay? Because and what I highlighted for you is these are the points that I calculated for our patient BA. Okay, so he's not 65, but he does have diabetes, he does smoke, he did have that prior PCI with balloon angioplasty, so that's a score of 3. His stent was because of an MI at presentation, so that's the score of 4 that I calculated for our patient, okay? Now the cutoff is 2. 2 and higher, there's a benefit to continuing dual antiplatelet therapy versus stopping. You can see that the number needed to treat to prevent any ischemic endpoint is 34. The number needed to harm for major bleeding is 272. That's a pretty favorable risk-benefit ratio. Whereas if your score is less than 2, so 0 or 1, you can see that the number needed to treat to prevent one ischemic event is 153, but the number needed to harm for bleeding is 64, and that's obviously in the opposite direction. That's where the cut point of 2 comes from. If you go actually into the DAPT study, on the website, you do the calculation, they'll actually give you more information in real time about sort of absolute benefits versus risks and what the absolute numbers look like. But so the score of 2 is really where the magic is in terms of the cutoff from where patients would benefit versus where they would not. And I calculated the score of 4. And so overall, what you could argue for indefinite therapy, I only didn't give you indefinite as a choice. I gave you months, and so I would argue for 30 months over 12 because his DAPT score is 4. Okay, other clinical pearls, just to round out P2Y12 receptor antagonists. Remember that for prasugrel, black box warning cannot be used in patients with prior stroke or TIA. Those patients in the clinical trial called Triton, not only did they not do better, they did worse. So they had worse ischemic endpoints, they had more strokes, and they bled more. No benefit at all to prasugrel in patients with TIA or stroke, and generally not recommended in patients 75 or older. In the labeling information, there is a suggestion that you could use the 5 milligram dose of prasugrel as opposed to the 10 milligram dose. In our practice, in my personal opinion, if you're thinking about 5 milligrams of prasugrel, just use clopidogrel instead. Right? I mean, they're pretty much very similar, and clopidogrel is obviously much cheaper. With ticagrelor, this is also a box warning. Can't be used with higher doses of aspirin beyond like an initial one-time loading dose of 325 in the cath lab. But for chronic use of aspirin, it has to be less than 100, which in the United States is 81 milligrams of aspirin. Okay, so you can't use high-dose aspirin if you're on ticagrelor. Lipid lowering, I'm not going to ask a question about lipid lowering. I know Dr. Morris covered lipid lowering, so I'm not going to spend a lot of time here, but not surprisingly, statin therapy is indicated in patients, in all patients with NSTEMI as a class 1A recommendation. Whether or not you choose to obtain a lipid profile, it's up to you. The guidelines don't comment very strongly. I know that Dr. Morris talked about the need for goals and looking at stuff like that. He did present this in some way. I'm just dicing this down a little bit further so you know the 4 statin benefit groups with ASCVD. The way they defined ASCVD in the guidelines is acute coronary syndromes, history of MI, unstable angina, stroke, TIA, and peripheral artery disease. So our patient has ASCVD because he had the MI. You know about the intensities. Dr. Mars did a better job. I didn't want to kind of rehash the data. But these are high-intensity statins. So you have atorva 40 or 80, and then you have rosuvastatin 20 or 40. And the high intensity, as you know, is a reduction in LDL of at least 50% or more. This is a study that led to the concept of high-intensity statins. It's a very long time ago. A study called the PROVE-IT-TIMI 22, which was one of the few statin head-to-head trials we have comparing pravastatin 40 to atorvastatin 80. There was an antibiotic arm to this. Thankfully, that failed miserably. Can you imagine if we had to give every single patient with acute coronary syndromes a quinolone, what a quinolone resistance would look like now if we'd been doing that for 10 years? Thankfully, that failed miserably. But they had a large composite primary endpoint of death, MI, documented unstable angina, requiring hospitalization and stroke. Now, I put this table up because in 2003 and 2004, when this study was stopped early, this made like national headlines. The way I kind of think of it, like in terms of the amount of press it received, if this was like the modern era today, like I think E! and TMZ would be covering this type of results. Like that's how big it was back in 2003 and 2004. Like everybody heard about the fact that this trial was like stopped because it was overwhelmingly positive. If we look at the actual data, I'd argue that they shouldn't have stopped the trial. Because, yeah, death is going in the right direction, but they didn't meet statistical significance. The death from coronary events, didn't meet significance. The MI looks good. It's in the right direction. Didn't meet statistical significance. The strokes didn't meet significance. But this revascularization and hospitalization for unstable angina, that was the only statistical benefit they had. And the reason I put this trial up is because if you don't actually look at the data, I mean, like, you know, in our institution, like, we still to this day worship at the altar of Lipitor 80, right? I think and most of us do. And now that it's generic, it's really easy to say, yeah, it's cheap and affordable, so why not? But when they stopped the trial early, the overall endpoint was positive, but the endpoints we care about technically didn't meet significance. So the Improve It trial, this trial took forever to come out, and then forever to publish thereafter. But the reason I'm presenting this is it's the most recent ACS lipid-lowering trial we have, which studied simvastatin alone versus simvastatin plus ezetimibe as the way to intensify therapy. So not just using one drug, but using the combination product to intensify statin therapy overall. You needed to have reasonable lipids to get into the trial, and then they had a minimum of 2.5 years of follow-up with that same broad composite endpoint of cardiovascular death, MI, hospitalization for unstable angina, coronary vascularization at least 30 days after randomization or stroke. Now, unlike the PROVE-IT-TIMI 22, this trial, like I said, it wasn't stopped early. It went on forever. It actually probably went on like 3 years longer than originally it was supposed to go on for. But at least in terms of the benefits, they found a benefit in MI. Didn't quite get stroke. It was close, but the p-value is 0.052. They did get ischemic strokes, but nevertheless, at least you can see that being on that therapy for a long time, this was a 7-year Kaplan-Meier curve that I didn't present, but this is 7 years of follow-up data overall. So perhaps the reason why PROVE-IT-TIMI 22 didn't show that benefit early was because it was stopped early. And it just takes a long time for lipids to truly modify events like MI and stroke. So stay tuned because, you know, the guidelines are very statin-centric. But it would be interesting to see if at some point in time they do address the fact that ezetimibe did have a benefit, small benefit, but a benefit, and potentially, if more than anything, I know that Dr. Morris briefly talked about the PCSK9 inhibitors. The secondary prevention trials are ongoing with those, and if anything, this type of data may open the door for that therapy sort of being synergistic with statins as a way to say that maybe that provides an additional benefit, and we'll see whether or not that's true and what the magnitude of that benefit is, and those trials are maybe 6 months to a year away, so stay tuned. Okay, so moving forward, our patient continues to experience worsening shortness of breath after PCI, attributed to volume overload. We do an echo post-MI and post-PCI. We see that he has global left ventricular hypokinesis with an ejection fraction of 30 to 35%. His current medications, so just to round things out, we've covered a lot of things. So we've kept him on aspirin. We put him on clopidogrel. We're worried about costs with ticagrelor and potentially adherence with a twice-a-day drug. So we switched him to clopidogrel. He's still on lisinopril 20. We increased the statin intensity to atorvastatin 80. We added carvedilol. We have a bowel regimen with sublingual nitro and Tylenol for pain. We stopped the amlodipine to allow for addition of ticagrelor, and we're temporarily withholding the metformin and the ibuprofen post-PCI because we're concerned about contrast-induced nephropathy and AKI post-PCI in the setting of either one of those agents. And so, which of the following therapies should now be initiated at this point in time to reduce his risk of dying or reduce mortality in our patient BA? Should we use valsartan, sacubitril, which is the brand new medication also known as Entresto? Should we use eplerenone, which is a aldosterone receptor antagonist? Should we use losartan, or should we use furosemide? Okay. Let's see what we got. All right, so the majority I would agree with here, that the aldosterone receptor antagonist of these four choices would be the best choice for our patient. And so what do the guidelines have to say about renin-angiotensin-aldosterone blocking medications? So ACE inhibitors in patients with an EF of less than 40 or with hypertension and diabetes or stable CKD, class 1A recommendation. That's not overly surprising, right? We all know about ACE inhibitors in this space. ARBs, class 1A if patients are ACE intolerant. And then the aldosterone receptor antagonists also have a class 1A recommendation as long as patients don't have renal dysfunction, defined as a creatinine above 2.5 or 2, they don't have hyperkalemia, who are already on an ACE inhibitor, beta blocker, or if they have diabetes. So our patient meets multiple criteria based on guidelines. Now, where does this class 1A recommendation come from? It comes from the Ephesus trial from back in 2003. And so this was patients just like our patient BA, post-MI, low ejection fraction, heart failure, on good therapy either because of diabetes or we're already on an ACE for hypertension. We're on beta blockers, diuretics, randomized to eplerenone or to placebo, primary endpoint being death from any cause or death plus hospitalization for cardiovascular causes. And like sort of the entire theme of the aldosterone antagonist trials, this was number 2 of 3. Thinking about sort of the landmark trials of aldosterone antagonists in the setting of low ejection fraction or systolic dysfunction. There was a reduction in all-cause mortality in the patients who received eplerenone versus placebo. The cardiovascular death or hospitalization endpoint was also significantly reduced in the aldosterone receptor antagonist group with eplerenone compared to those that did not. Now, you all know the price to pay for being on an ACE inhibitor plus an aldosterone antagonist is hyperkalemia. Right? So that was shown in this trial. There's been other data that have shown clearly that risk increases, and so that is the price to pay for being on combination therapy. The benefit, though, is reduction in mortality. So that is, from the overall grand scheme of things, that is a pretty attractive risk-benefit ratio, but we do have to worry about hyperkalemia. Which brings me to my next question. How can we try to minimize the risk of hyperkalemia in our patient BA? So should we monitor the serum, the potassium only 4 weeks after discharge? Should we monitor both creatinine and potassium 1 week and 4 weeks after discharge, or should we obsess over it? Should we monitor both, but we don't have to necessarily be all that crazy. As long as we have labs in-house, we can wait a month outpatient and check both of those there. Or is it not really about the potassium, it's just about the creatinine, and we can check that a month later? And survey says, oh yeah, large majority here, absolutely correct. We do have to obsess over the creatinines and the potassiums. So the guidelines, there's a variety of guidelines. The heart failure guidelines, this is the HFSA. The ACC-HA guidelines that have been published, I think, do another really good job as well. The heart failure guidelines, so I won't touch upon that too much. There's another presentation on heart failure. But the guidelines basically said that you should monitor potassium very, very closely following initiation or change of aldosterone antagonists. And the heart failure guidelines actually take this a step further, but I won't get into that at this point in time. I'll let Dr. Betts cover that in his presentation tomorrow. And they said that the monitoring should reflect the protocols in the clinical trials. And this is what was done in the clinical trials. It was checked very, very frequently. So from hospitalization to discharge to home, it was checked at 1 week and 4 weeks and then serially thereafter over the first year. And then also during any dose changes of either an ACE or an ARB or the aldosterone antagonist, you repeat the cycle all over again to really minimize the risk of hyperkalemia. And that's the way in which we can successfully keep patients on both mortality-reducing medications. So this is just that spoiler alert, I guess. This is what I talked about. So this is what they actually did in the EPHASIS trial. The emphasis was the sort of the newer heart failure trial with the Plerinone. This is the trial that led to the guideline change in heart failure, but that doesn't meet our patient, so I'm not going to present that here. Okay, thinking about smoking cessation and quality of life. Which of the following changes in quality of life are likely since he's experienced an MI? So we encourage him to stop smoking, but which of the following changes in quality of life are likely since he's experienced an MI? It will worsen if he continues to smoke cigarettes. It's not going to change at all because if he continues. It'll improve if he switches to e-cigarettes, or it won't change at all if he switches to e-cigarettes. How will smoking impact his quality of life, whether he continues or stops? And let's see what we got. Yeah, I would agree with the large majority. His quality of life will continue to worsen as he continues to smoke. And that was actually, so the guidelines, I call this the Captain Obvious statement, right? Like this is the easiest statement you can make in a class of guidelines as a Class 1A recommendation. Patients should avoid and stop smoking after you've had an MI. So this was a study that was just recently published looking at quality of life and a bunch of other endpoints in patients who either stop smoking at varying points in times after their MI, or if they continue to smoke after their MI. And so compared to patients who had never smoked with regards to quality of life, as you can see, that the longer you continue to smoke, the more likely you are to have a worse overall quality of life. So by continuing to smoke, even though it's an addiction and this patient may feel better, overall, he'll actually be worse by continuing to smoke, which isn't necessarily a big surprise. Some of that may be explained by angina status. So patients who continue to smoke, not surprisingly, have worse angina scores than those that either stopped, who were former smokers, or who never smoked at all. So if you can stop, you start to come back towards the line of neutrality and approach the former and never smokers. But if you continue, not surprisingly, your angina symptoms are far worse. And this wasn't the only thing that drove quality of life. There were a variety of other things that drove quality of life reduction. Infections, other things that kind of played into that. So continuing to smoke, not surprisingly, will detrimentally impact his overall quality of life. A variety of guidelines talk about ways in which you can counsel patients for stopping to smoke. The 5 A's are commonly published as a way to approach it. So ask the patient if they smoke, advise them to quit, assess their readiness to quit, have an assistance plan, and then arrange for follow-up. Now, with regards to pharmacotherapy, as you all know, we have a variety of options, right? There are a ton of agents that we could use. And then even if you dice down the nicotine replacement therapies, we have a variety of options as well, and a variety of formulation, everything from patches to gums to inhalers and sprays. We have bupropion, varenicline, and then you can get into other second-line therapies. What I'm presenting here for you is a really good resource. It's called RX for Change. The URL is actually listed in your handout. It runs through UCSF. And I thought there's a lot of really great resources for us as pharmacists. If you happen to be in this space, or you're curious about smoking cessation, or you're involved in counseling in one way or another, I thought this was a really great resource. And so they advocate that you basically can pick 1 or 2 long-acting therapies and then pair them with 1 or 2 short-acting therapies. And so good take-home points are, that nicotine products work really well. If you look across the data, combination nicotine products work better than a single nicotine product. So if you're using nicotine, it should be 2 therapies. Even if you're using bupropion, you should consider some short-acting rescue type of therapy overall. And then in terms of thinking about when to start pharmacotherapy, for the most part, with the exception of all nicotine-based therapies, if you're thinking about other oral medications, it's important to think about setting a quit date and then starting 1 week prior to that quit date, and then having these stars represent follow-up, so having essentially monthly follow-up at a minimum to make sure that patients are successfully quitting and that they're not experiencing adverse events and they're on the path towards smoking cessation. Other smoking cessation-based resources, there's a ton that are out there. This is by no means a complete list, but I tried to break them down into a variety of sort of groups. So this is the RX for Change. I'd strongly recommend you look at this. There's a lot of really good evidence-based unbiased. It's all sort of run through UCSF, so it's very, there's a lot of good resources there. There are other support groups that are non-pharmaceutical based, and then the pharmaceutical companies themselves on their websites have their resources as well. So there's a variety of options. If you are in the space, you probably have explored this a fair amount. But the good news is that for patients who are thinking about stopping, that there are resources that are available to them. Okay. Now, thinking about NSAIDs for osteoarthritis in our patient, what should we do? So should we put him back on ibuprofen 3 times a day? Should we encourage naproxen at 220 twice a day? Should we switch to Celebrex at 200 milligrams twice a day? Or should we switch to diclofenac at 75? All right, I would agree with the majority here as well that naproxen at this dose would be, of the 4 choices, being the best, with the caveat that, if you wanted him to see a rheumatologist and have him stop NSAIDs altogether and think about other therapies, I think that would be reasonable as well. I didn't give you that choice. Amongst the NSAIDs, this would probably be the one that I would pick as well, and I'll kind of walk you through the data surrounding NSAIDs in patients with cardiovascular disease. And so, with regards to what the guidelines have to say about NSAIDs, they basically say, assess the need for them to even be on therapies, and there are a variety of options that can be considered. If you're going to use an NSAID, they actually did highlight naproxen as one of the agents that they would consider using. And then they also mentioned the COX-2 inhibitors, and this is really getting more not at celecoxib, but this is really more getting at the ones that have been removed from the market, and how those were removed because of the MI risk. And so all NSAIDs appear to increase the risk of MI in patients. They appear to increase the risk of heart failure in patients. And also, not surprisingly, they appear to increase the risk of GI bleeding. But are all NSAIDs equal in terms of their risk? This is where there's been a lot of fairly recent data that has been published trying to attempt to see, are these all equal opportunity offenders, or are there some that are worse than others? Does dose matter in some way, or is it just exposure to the agent one way or another? And so this was a study, an evaluation of NSAID use for death and MI in individuals who didn't have cardiovascular disease at all. And so you can see that all NSAIDs are associated with a risk of having cardiovascular events, but they obviously differ in risk, where the COXIBs are much higher than drugs like ibuprofen, diclofenac, and naproxen. And with regards to naproxen, it had the lowest number needed to harm of 1,329 before you'd have a patient who'd have a cardiovascular event. And that was fairly close to patients who had never been on NSAIDs at all. So this is sort of the background risk of MI in the overall cohort of patients. Now, looking at type of NSAID with regards to MI, this was a very, very large meta-analysis for the COXIB and traditional NSAID trialist group. At the end of the day, when they included all of the studies, it was a Herculean effort, but we're talking about 600 plus clinical trials in almost 350,000 patients that are in this meta-analysis. So it was a very, very strong, from a design standpoint and from the sample size, was a large meta-analysis. And this meta-analysis was used by the Europeans and by the FDA in their consideration of how they're managing NSAIDs in this space. And so, as you can see, even with regards to NSAIDs, that there appears to be differences in risk overall. So not surprisingly, the COXIBs rank pretty high with regards to risk of death or MI. This is now coronary, so this is all related to cardiovascular death or MI. Diclofenac, as you all know, also has a significant risk which approaches what the COXIBs approach. So I kind of think of them, even though mechanistically they're not the same, but I kind of think of them similar in terms of their risk from a cardiovascular disease perspective. Even ibuprofen was associated with increased risk, but naproxen was not associated with a risk in this particular trial for patients who had events who were then evaluated for subsequent cardiovascular death or MI. Now, with regards to dose, does dose matter? For the most part, it does not in the overall risk. However, in terms of is there an additive risk with additional dosing or with higher doses, I do think that there's a signal that there is somewhat of a dose-dependent nature. So I know this is a hard slide to read. This is the reference here for you where I pulled these two graphs. As it relates to death, you can see that for the most part, the potent inhibitors of COX are more likely to increase the risk of death, regardless of dose, although the higher doses are far more likely to contribute to that. With ibuprofen, as you can see, at 1,200 milligrams per day or more, there's a greater risk than at less than 1,200 per day. And same thing with naproxen, dosed at less than 500 versus more than 500, there is the risk there is the play that dose here does matter as well. With regards to MI, a similar theme with regards to whether or not there's an impact of dose. You can see for the most part that sorry, just want to make sure I'm okay on time. Is it okay if I take a question at the end? I'm not trying to ignore you. I just want to make sure I get through my content. Sorry, I just don't want you to keep your hand raised for like I'm. Okay, no worries. Okay, so moving on to question 10. Which of the following represents the best acid suppressive medication therapy option for this patient? Should we put them on a PPI like pantoprazole, esomeprazole, omeprazole, or should we put them on ranitidine twice a day? All right. Okay, so we have a split between A and D. I'm going to tell you why, as much as I don't like my answer to my own question, because I'm not a fan of PPIs overall, but in this particular patient, I think you could argue for a PPI over ranitidine, and you all identified the most appropriate one. So with regards to like guideline-based statements for patients who require dual antiplatelet therapy, remember that if we're continuing an NSAID in our patient, he's now on naproxen twice a day, plus aspirin, plus clopidogrel, right? So that's 3 different agents. So that would warrant GI prophylaxis with a PPI in multiple guidelines. Now, with regards to clopidogrel and PPIs, this is incredibly controversial. I'll try to make this as painless as possible, although hashing through the data over the years for me has become more painful than I had ever imagined it would have. It's incredibly controversial, as you all know. There's a large variety of studies that say, yeah, there is something going on. There's a lot of studies that everyone likes to highlight that say, no, it's completely bogus. I'll try to provide a fair and balanced approach to both in a quick fashion before I tell you my overall take-home points. And so, looking at, I'm not going to present the case control data because it's mixed on both sides. What I thought was interesting, and this is one of the things the FDA strongly considered when they weighed in on the interaction overall, was this trial in healthy volunteers where it was a crossover trial. So everybody served as their own control, which is really very interesting. So everybody got either pantoprazole plus clopidogrel or omeprazole plus clopidogrel. They did the platelet reactivity studies, washed out for 5 days, and then they switched. So the patients who got pantoprazole got omeprazole and vice versa. And so when, to me that adds a little bit of power because now it's not, are these patients all different, because the patients are all the same. And they got both agents, and there's no variation with the clopidogrel necessarily. So what you can see here, this is the clopidogrel patients who received omeprazole, where day 1 there's no difference at all between the two groups, but then as you expose these patients to the PPI long term, you'll see that in the patients who only got clopidogrel, there's a very nice platelet response, right? So we're reducing platelet activity with clopidogrel, and this is what we'd want to see. But surprisingly, we're seeing that there's something with omeprazole here that is blocking the response of clopidogrel. So these patients, by 5 days, have a significantly higher platelet reactivity than the patients who were just on clopidogrel alone. You take those same patients, you now change the PPI, and we see much more similarities across the board where there are no significant differences between the groups that receive pantoprazole. Now that's not looking at outcomes, that's just looking at platelets, but you can see that in these patients where they are their own controls, their platelets behave differently in the setting of omeprazole versus pantoprazole. The Cogent trial is what everyone likes to quote. If you want to say that I don't believe this interaction, don't talk to me about PPIs, I don't care. This is the trial that everyone quotes because it's the gold standard of trials. It's the randomized, controlled trial. And in this study, they used a fixed-dose combination because this is what they wanted to bring onto the market, a combination pill with omeprazole plus clopidogrel. The clopidogrel got released first, and then the omeprazole would get released about 6 or 8 hours later. And they were studying GI endpoints. And so that's what often gets lost is initially in this trial, that was their objective. It was gastrointestinal endpoints. It really wasn't cardiovascular endpoints they're trying to study. They added that in, but initially it was supposed to be a GI endpoint trial. And they were supposed to have 3,200 patients, and they were supposed to follow patients for at least a year, if not 2 years. Well, they had a really low event rate with GI bleeding, and so they missed the mark, and they had to increase their sample size to 4,200 and ultimately to 5,000 to try to get 100 plus GI events. And then the study ends because this is in 2009 where the economy turned down, and through no fault of their own, the company went bankrupt. So can't blame them for that, but when you look at what happened, they didn't quite meet their enrollment. And the mean follow-up in this trial was not even 4 months. It was 106 days. They didn't quite get the GI events they were looking for their primary endpoint, which they wanted 143. They only got 55, but then everybody looks at the result and say, hey, well, you know, when it came down to the events, it was only 55 versus 54. That should clearly show that there's no difference, right? I mean, I think that doesn't pass the statistical muster of anyone's definition of power, endpoints, long-term follow-up, et cetera, right? But this is a study that everyone looks at. So the way I think of things is the data is mixed across the board. But the FDA weighed in, and they said, you know what? There's something here that we can't quite explain, but we don't want to, we don't necessarily think that this is good. And what they did was they kind of made everybody guilty by association. So not only did they take clopidogrel, but they took every single 2C19 inhibitor, and all the potent ones especially, and said, you're all guilty. We're throwing you all in jail. You can't use them. And so this is the label change. And so the way that I think of things, and thankfully I have a group of cardiologists in my practice that agree with me, is, if you have a patient who, for whatever reason, develops stent thrombosis, and they happen to be on omeprazole, isn't that an easy victory in terms of the court of law? The lawyer just has to bring in the package insert and say, well, the United States FDA said, you should not use omeprazole or esomeprazole. Why did you do it? I don't think a judge or a jury is going to want to get into a journal club with a Cogent trial and sort of say, well, that's the reason why I should not be sued, right? I mean, just think about your own enthusiasm for hearing what I just presented. I don't think you'd want to hear it either again, right? I don't think a judge and jury would either. And so this to me is an easy win. And so thankfully I have a group of cardiologists that agree with me and say, yeah, it's just not worth it. If we're going to use a PPI, let's just use pantoprazole. It clears the error and clears the risk of having any sort of risk, so to speak. Okay, so moving on. If our patient BA is interested in a support group that allows him to meet other MI survivors, which of these would be the best to recommend? So would it be the American Heart Association Support Network, the Iron Heart Foundation, the American College of Cardiology, or Mended Hearts? So if he wants to meet with other survivors face-to-face, kind of in a room like this, or, have the ability to talk, commiserate, figure things out, how'd you do? Okay. Most like the American Heart Association. I think Dr. Mars might have biased you because I think in one of his answers it was American Heart Association, which was the right answer. It's not that they don't have resources, but in terms of face-to-face contact, Mended Hearts is really the only one that actually allows for community-based care where patients can go and find not only within their state or their city, but often really within their neighborhood, so to speak. But it's far more local, grassroots type of thing. The American Heart does have resources that are available to patients, but it's not full face-to-face. If anything, it's more of an online community, and there's a bunch of other resources, so I'm not trying to say the American Heart isn't good. There's a lot of resources, but I asked you about face-to-face. I asked you a very specific question. The Iron Heart Foundation is really interesting because they try to they have an approach of, we're going to make cardiovascular disease, even though you have cardiovascular disease, we're going to minimize that on your life, and we're going to have these really big cardiovascular events. They do a lot of races and a lot of Ironman triathlons, so there's a lot of stuff that's available for those patients as well. The ACC defers to Mended Hearts. So that was actually a total incomplete answer because they don't have anything on their own. They just defer to the Mended Hearts organization. So 2 years later, our patient's now, we're going to fast forward 2 years, so he's admitted for decompensated heart failure. His past medical history is essentially the same. He's picked up GERD from all the agents that he was on. His agents, for the most part, have been the same, so he's still on doing platelet therapy. He's still on his lisinopril, eplerenone, high-dose statin. We've titrated his carvedilol a little bit. He's still on metformin, etc. So his sodium's 130, his potassium's 4.8, his creatinine's 1.4. We have no ischemic etiology for why he's coming in for heart failure. His echo is 30 to 35%. His exam is suggestive of heart failure. He's got a pro-BNP that's elevated, so it's all pointing in the direction of volume overload. Now, with regards to his beta blocker, what should we do to it? Should we leave it alone? Should we reduce it? Should we increase it? Or should we discontinue it altogether? Just temporarily withhold it? And survey says, okay, somewhat of a mixed bag here, but we should leave it alone. I'll kind of walk you through why we shouldn't try to titrate at this point in time, because he's volume overloaded and we don't have to stop it or withhold it. And so the one major trial that's actually evaluated this is called the Be Convinced trial, which was somewhat of a small study in the heart failure space. But in patients with heart failure with congestion, they were randomized to either continue therapy or stop therapy for a minimum of 3 days. And what they evaluated were endpoints of dyspnea from the patient perspective and from the physician perspective. And what was interesting was that in the patients who continued therapy, they actually felt better than the patients where they actually stopped the beta blocker altogether. So that's one thing. But then, more importantly, looking at the differences long term, in patients who continued therapy, they were more likely to have a beta blocker at 3 months, and the dosing was far more appropriate in terms of at the target dose or at half the target dose. And remember, that's the most important part in heart failure, right? It's not just the drug, but it's the drug in the right dose. And so by stopping beta blockers in these patients, we're kind of shooting ourselves in the foot. We have to reset that timeline altogether to get them on the drug and get them on the right dose, whereas if we just continue it and leave it alone, we're better off long term. So that's why we should just continue therapy. And that's what the guidelines say for beta blocker, for patients who are on beta blockers. Unless you're thinking about someone who's like in the intensive care unit who needs inotropic support, at that point in time you consider withholding therapy, but that's not where our patient is at this point in time. Okay, so you should continue therapy and just ride it out with other agents. So in addition to diuretic therapy, which of the following should we use at this point in time to manage hyponatremia? Should we use tolvaptan? Should we use hypertonic saline? Should we use normal saline? Or should we just fluid restrict? And survey says, yeah, I would agree 100%. Yep. Fluid restriction is by far the best choice here. So with regards to hyponatremia, there's been 2 sets of guidelines that have been published. This is like a global hyponatremia guideline from Verbalis and colleagues in 2013. So if you see patients with all sorts of etiologies of hyponatremia, not just from heart failure, but from liver disease or from SIDADH, this is actually a pretty interesting guideline to read. I thought they did a nice job. So they recommended fluid restriction, a pretty strict fluid restriction of 1 liter per day. Obviously to recommend loop diuretics, which we would do anyways, and only for patients who are severely symptomatic or with very rapidly falling serum sodiums should you consider hypertonic saline, and then if it doesn't correct beyond that, to consider using the vasopressin antagonists. The Heart Failure Society of America, in their guidelines for hyponatremia, they had a little looser definition for fluid restriction for 2 liters per day, which for most patients I think is a little more liberal, a little more generous. It's not terrible. 1 liter per day is really, really strict. And then for the vasopressin antagonists, a very soft recommendation from the ACC-AHA heart failure guidelines, only for patients who have severe persistent hyponatremia or for those who are having cognitive impairment despite water restriction and on guideline-directed medical therapies like diuretics, can you consider using a vasopressin antagonist. So you have to go through a bunch of hoops, so to speak, before you should jump to those. And then remember that there is some risk with using these agents, and this is more with chronic use, but with tolvaptan, there was a warning back in 2013 in patients who received this drug beyond sort of acute dosing for risk of liver injury for patients who are on chronic therapy. So these agents are often just used in-house as one-time doses or a couple doses here or there to cause the sodiums to rise, but not to be used chronically. And so thinking about transitions to care a little bit, this has become obviously an important issue in the healthcare field today. And so the heart failure guidelines, I thought, did a very nice job about thinking about all of the aspects that go into transitions to care. So initiation of guideline-directed medical therapy. So Dr. Betts will talk about this a lot more tomorrow. But guideline-directed medical therapy is sort of all of our classic medications or our class 1A or our evidence-based medications. Think about causes of heart failure, think about barriers to transitions of care and limitations post-discharge, assessment of volume status, which is often challenging clinically, but trying to get a really good grasp of volume status throughout someone's hospitalization. When can you titrate and optimize heart failure therapies? Assess renal function, electrolytes as appropriate. Remember, depending upon our medications, we can do that more or less frequently. We touched upon that a little bit with aldosterone antagonist dosing and how we can manage those. Other comorbidities, heart failure education, self-care, emergency plans. Adherence is obviously important in these patients. Right? We all know that patients don't get the benefit if they fill the prescriptions, they actually have to take them. And then they went even down into sort of the end-stage heart failure patient, when to think about palliative care and hospice. So they did a really nice job of thinking about transitions of care, which has obviously become important in the healthcare system today.